Hello, I'm Saeed Sadeghi from UCLA Health, and welcome to Blood Cancers Today virtual roundtable, the latest in low-risk myelodysplastic syndrome management. I'm joined today by our panelists, Dr. Clark Alsfeld from the Ochsner MD Anderson Cancer Center, Dr. Thomas LeBlanc from Duke Health, and Dr. Raji Shameem from Orlando Health Cancer Institute. I think to start, wanted to get everyone's perspective on the first-line treatment of low-risk myelodysplastic syndrome, and specifically how erythropoietin levels as well as ring sideroblast status affects your treatment decision.
Yeah, I can start off and chime in and just say that historically, this has been really important. And we've known that patients with RS negative MDS have had worse outcomes in general, and that patients who have moderate or particularly high serum EPO levels have had historically poor responses to exogenous EPO. But really, with the emerging data from the COMMANDS trial and now the longer analyses, a lot of that's kind of being turned on its head in some interesting ways that we're here to talk about. And so I'll pass it over to my colleagues here on the panel to maybe say a little bit more about that in their practices.
Yeah, I would definitely agree with all that. Landscape changed dramatically. I would say, low-risk MDS wasn't always exciting. Now it's going to become quite exciting. We got new options for our patients. I still check a EPO level. I think it's just what I'm so used to. But does it change my frontline therapy for my low-risk MDS patients with anemia? Not really, because luspatercept, based on the follow-up data, the durable responses, in the COMMANDS trial, patients with baseline EPO levels greater than 500 were excluded. But I think that's because it was comparing to ESA therapy, right? So I feel that luspatercept would still work for patients who have an EPO level greater than 500. And I feel in the subset analyses, which we'll review, we see a consistent benefit for EPO level less than 200 or greater than 200. But yes, I still check it at my EPO level, but my frontline therapy doesn't change.
I will also chime in. I apologize. It's storming out here in New Orleans, so if you hear thunder, it's going to be okay. But I also still, just out of habit, more so check an EPO level at the time of diagnosis. Obviously, evaluate for other contributing etiologies as well, copper deficiency and other things, as we standardly do. For us here, especially in New Orleans, we're uniquely positioned and have a bit of a different, approach in that we are the referral center for the whole state of Louisiana and most of the Gulf South. And so for a lot of our patients, time in the infusion chair, time to get to and from the infusion chair, that matters a lot. And so on top of the data, the logistics of luspatercept, for us here in New Orleans, it's a huge benefit to have a weekly, every 3-week injection over every weekly injection, or if you can get every other week approved. So luspatercept, on top of the benefits that we know from the trials, it also has a logistical benefit that I very much appreciate in my practice.